everybody. Thank you so much, Dr. Licht, for starting us off. My name is Jackie. I'm a genetic counselor. Sorry, at Sick Kids. And I'm really looking forward to talking to you a little bit today about sort of genetic counseling. How does this apply to sort of now, the future, family planning, and kind of the aspects of life? And just no conflicts of interest to disclose. So why are we sort of thinking about this concept of genetics when we think about aHUS? And that's primarily to Dr. Licht's point, as he mentioned that primary aHUS, we think typically has a genetic association. And it has been estimated that when you take all individuals with the diagnosis of aHUS and put them in a room, about 60% of them will likely have a genetic pathogenic variant, or what we may call a mutation. That's the ultimate cause of that history. So that means we do estimate that there is a very high proportion of individuals that have genetic associations as to why, or as a contributor to why they've developed that symptom. And sort of as time has passed, as we've learned more in terms of the implications of now and the future, genetic testing has therefore played a key role in how someone may be treated or managed over time. So then why do we think about genetic testing? A big part of it for many can just be confirmation and ultimate diagnosis. Essentially, we found a mutation, a pathogenic variant in a gene associated with aHUS, and we can say this is like not necessarily the full answer, but at least part of the very big reason for why this developed for that patient. But that can also play a role to the family at large. What does this mean for my children? What does this mean for my siblings? What does this mean for my parents? And how we think about things overall. I think one of the big things I often tell to a lot of my families is that genetic does not always mean familial. Someone could have a genetic change that's new in them that is not necessarily inherited. But in aHUS, because of what we call the decreased penetrance, basically the concept, as Dr. Licht mentioned, that not everybody that has a mutation will develop symptoms. These are typically inherited and therefore play a role in thinking about the family at large. And so this sort of leads families down the path of what we call the diagnostic odyssey, that there's an initial clinical diagnosis and then sometimes a path towards even getting the genetic testing and then understanding those results when they come back. And we kind of call that the odyssey because it is typically takes time. It can sometimes take advocacy of like, I want to see a genetic counselor or geneticist. And that can be a long and hard process, though we hope to always increase that access and ensure that that's becoming more available over time. So then why do we even think about obtaining that diagnosis? So as I mentioned, it does potentially have the possibility to change medical care, mostly from the perspective of what does this specific gene tell us about future recurrence, about severity, for instance. It could potentially allow for a referral to a specialized center, allow for appropriate recurrence risk counseling, more targeted resources. Certainly, some people always think, well, if I have this history, if I develop this, is this my fault? Is this something I did? Why did this happen? And sometimes a genetic reason can just say, like, this is not your fault. So that can sometimes sort of lift that off from a person. It can provide that validation, like, yes, there is something going on, provide that confirmation for self. We found more information, which can sometimes decrease distress, allow for information like prognosis, sometimes improvements for quality of life, acceptance, but also obtaining a genetic diagnosis is not necessarily benign either. It can be a shock for someone to think about, wait, this is genetic, this is due to a change in a gene, what does that mean? What does that mean for my life going forward now that a lot of these genetic forms typically have, as Dr. Licht mentioned, thankfully, the data is before the onset of treatment, but what does that mean for future recurrence? It can involve like coping with a change in perception of self. How does this change how I see myself? That now I have like a genetic predisposition, a condition that explains what's been going on. That can sometimes be validating, but sometimes be advent of distress? Could it be a shame of, I pass something on, I carry something? That these are not necessarily benign things. It can make something real, and that can be something that takes time and counseling often to sometimes come to terms with. So there's sort of balances in all aspects of when we think about genetic testing. In terms of the actual concrete process, certainly we tend to think that the best person to test first is the person who is affected first. That's because if we test sort of an unaffected family member, are they unaffected because they're in that 50% that just hasn't had symptoms yet? Or are they unaffected because they truly are negative? Therefore, they're not necessarily an informative person. They're not necessarily a true negative. So certainly, we typically test the individual who's been affected first. And then typically, if there's a family history, we always like to do it typically at the same lab, making sure essentially that we know the exact change we're looking for and that we're looking for it specifically. And so usually if we're, say, testing a sibling, we like to do it at the same lab, making sure essentially we're looking at the right thing that we should be. And so that can sometimes then be the role of the genetics provider in a clinic. We can help ensure that you receive appropriate counseling about what does the test look like, what are the types of results, how does that feel for you, is this something that's an interest for right now, or hey, maybe let's put it off for a couple of months because maybe just now doesn't feel the right time for you as a family. And then we can help interpret results. Yes?
Are these, like with our son, some tests were sent to a lab in Germany. Are these tests being sent to another country, like in Calgary or something? Or are these tests being done fairly locally?
So it depends. And I have a slide going over this in a little bit. Different labs test different genes. And so it's always a complication of like, do you do a test here where it maybe only tests 4 genes? Do you do a test in Finland that tests 13?
And sort of follow up is would same family member genetic testing be publicly covered?
Typically, yes, at least in Ontario. Yes. So sort of to that point, testing is usually done via what we call a gene panel. And so that's where we don't necessarily look at absolutely everything, but we focus our attention on the genes we know to be associated with a specific symptom. So just sort of broadly, panels can always vary. They vary between lab to lab, and that's often can be a benefit of leveraging the expertise of your nephrology team, if they have genetics colleagues, about what panel do they think is most appropriate and most helpful. In terms of technology, it's typically what we call next generation sequencing. So this allows us to generate a lot of data, but sort of focus our attention on the genes we know to be associated with what we're looking for. A benefit of targeted gene panel testing is usually that's a little bit faster than like big, broad, huge testing. And it's useful when in a specific phenotype is known, where we sort of know the genes we know to be associated with aHUS right now. And certainly this is a bit of a complicated side, but I would just like to mention when we think about next generation sequencing, a complication of this technology is it actually involves the cutting up of the DNA into very small fragments and then sort of sequencing all of those fragments together. What that kind of means is it doesn't sort of sequence things in like one long big sentence that keeps going on and on and on. It's little chunks that they kind of overlap with each other, and that's kind of how we get the sequence as a whole. But it's not one long sentence. What that kind of means is that certain genes can have certain coverage challenges. If they have a region where there's lots of repeats, for instance, it's just AG for a while, you can't necessarily tell exactly how long it is by this technology. So all to say, it can sometimes be important when you're receiving genetic testing to sometimes ask, what's the technology? How is this being used? Admittedly, this is kind of the technology right now, but long read sequencing, where we do just sequence those big long letters, is coming down the pipeline, which may allow for more specificity in sort of targeting sort of the full sequence, not missing anything. But I think also importantly, when we think about the genome, that is not all of our genes. our genes, our instructions, are really only about 1% of our genome as a whole. We consider our genes the most important information. We sort of think they are the pieces that become the protein. The protein is what does the work in the cell, in the body. But there's lots of information sort of between those genes that you may have learned in high school as like junk DNA, but now we know as sort of just non-coding. It does play a role in how genes are expressed, but we don't really know how to interpret all that information yet. And so down the line, we will potentially be moving to more genomic sequencing of these regions, because it's possible that somebody has a change in one of those little intron regions that doesn't like become the protein that is maybe changing how that gene is expressed, but we just don't know how to look at that yet. And so an important consideration of testing is always sort of what's the technology, what's the coverage, what was looked at, because a negative genetic test, and I'll go through this in a bit more detail, doesn't mean someone might not have a genetic change. It just might mean the technology and the knowledge isn't there yet. And so, as you kind of see, these panels have different genes that they test. Some of them are in Ontario, as in Sick Kids and London Health Sciences. And there is a lab blueprint that's in Finland that also has a gene panel. All of these are good in different ways. The panel, for instance, comes back pretty fast and looks at the most common conditions. A blueprint panel may take more time, but looks at more. So it's often a balance and a discussion with care team and the genetics provider you're meeting with about what they feel like might be the best for the patient at that specific time. But as I've kind of indicated, there can be a lot of complexities in genetic testing. Certainly we have the chance for a positive result where like we find that answer, we sort of get to the end of the diagnostic odyssey with this is why, but there are even complications in that as well. Does it explain the current symptoms only and sort of gives us that insight, or does it tell us other things we now need to watch for, unexpected things? For instance, for variants associated with the gene DJKE, there can be other broader kidney associations with that gene that now we need to think about. So that can also be important to why genetic counseling can be useful of like what can be what we find. But we can get a negative result or an uncertain result where we find a change in a gene we've just never seen before. Is this a mutation? Is this benign? We have hundreds of thousands of variants that just make us who we are. So a change being present in a gene alone doesn't necessarily mean it's always doing something just because it's there. And that can be a place where a genetics provider can be useful to think through what is this variant? Has it been reported before? What are the computational data, for instance, to at least give you our best recommendation of what we think an uncertain result might mean? So to sort of use one gene as an example, so CD46, also known as MCP, is sort of one of the genes we know to be associated with autosomal dominant susceptibility to hemolytic uremic syndrome. But what does that susceptibility even mean? And that's sort of referring to that decreased penetrance that we mentioned earlier. That just because a person carries a variant, it doesn't mean that they will develop symptoms, but they have that susceptibility to develop. And this is gene dependent. So genes will have different penetrance. They're usually around the 50 to 60% range, but you notice that's not 100%. So there's many individuals that may carry mutations throughout their lifetime and not necessarily develop any symptoms, while someone who does in the next generation might. And that's of no fault of any of those individuals for like doing anything different. Oh, I went here or I ate this. It's sort of no fault. And we're certainly learning some of the triggers. But it can be sort of a complicated process when someone thinks about their own risk. And so this is just one slide exhibiting an example of decreased penetrance. Certainly there are genetic conditions associated with 100% penetrance. You have the mutation, you have symptoms. But in the case of aHUS, this is typically the case where we're thinking about this reduced penetrance. Not everybody will develop symptoms. In case of, again, using CD46 as an example, you need only sort of one mutation, one pathogenic variant in order to have that increased risk. But having that increased risk means you can potentially develop symptoms at any time through life from childhood to adulthood, and penetrance is estimated at that 53%. But sort of knowing that someone may have a variant in CD46 can be useful over some other genes, since we know that variants in that gene actually tend to have a less progressive and less severe course. So knowing that gene over another another can sometimes be useful. For instance, about 80% experience complete remission with CD46. And certainly, as Dr. Lick mentioned, there have been relations identified with some stressors in this case as well. So what does this mean for family members? If we've sort of tested that first person initially, typically we start by testing parents because we want to see, is this inherited or is this de novo or new? We all have changes new in us that aren't in our parents. So there's always that possibility. So we want to make sure, let's test parents first before we necessarily think about needing to worry about testing siblings, aunts, uncles. And the sort of complication here is a family can look unaffected, but just maybe not have had that trigger, maybe just didn't by chance ever experience symptoms, just maybe not at that age. Maybe they will still develop symptoms over time. So a complication could be that families can look unaffected, but maybe still be affected through multiple generations. And if inherited from an unaffected parent, that does mean we're thinking about a 50% risk for siblings. But the complication there is, what is then the full utility of testing those family members and siblings when there's not necessarily a lot of concrete medical management changes on a baseline we'd necessarily do for like siblings who may carry that mutation. A lot of it can be like if there's a trigger, specific monitoring sometimes at that point. But then what does it mean for that person of like, do I want to test myself knowing I just might carry this risk throughout my life and there's maybe not necessarily anything I can do about it? Is that something I want to know? Is that something that I just don't want to know? Some people say like, I'd at least rather know like if it's not something I have to worry about, but maybe we're thinking about challenges of like survivor guilt or shame of like, I don't carry it or shame that I do. So there's often a lot of complications, but even the decision to test. And so that can be another way that a genetic counselor can be useful. I know we're at time. Keep going. Okay. Any questions here? Okay. And certainly there are complexities of the inheritance as well. As Dr. Lick mentioned, majority of these are what we call autosomal dominant, all with variable penetrance, which means that you sort of only need that one variant to cause symptoms. And that means when we have kids, we pass on one or the other. There's a 50% chance in these cases of these genes that that would be passed on. And so there would be risk for siblings, risk for someone's own children. And then that can often be important to consider at the timing of like family planning, for instance. Are there options of maybe what I can do with the thought of reducing that risk for my future children? But there's also the fact that some of these are autosomal recessive, like DJKE, for example. A carrier of one pathogenic variant is not affected. It's only when a person inherits a variant from mom, a variant from dad, meaning they don't have any working copies of that gene, when they have symptoms. And so when we compare this to autosomal dominant, this is where like parents, we would not expect to be affected. Siblings may have about a 25% risk, but risk for the next generation is very low because we'd still expect that that future child would have to have both gene copies affected. And so they would also have to inherit a variant from that affected person's other partner, not just themselves, in order to have a risk to have a child with aHUS risk. But these typically have a higher penetrance with an earlier onset than some of the autosomal dominant associations. So as I sort of mentioned, well, if we sort of have a mutation, have a pathogenic variant, what can we do with it outside of testing family members? And so family planning can be an option for some people that they wish to pursue. For instance, this can even include something like IVF. They can do something called pre-implantation genetic testing, or PGTM, where they actually can look for the specific variant in those embryos. And say you want to say, I really want to ensure that I don't pass this on, then this can be a way to be like almost 100% certain that we're only implanting embryos that aren't affected. Though certainly this is an involved process. It can be expensive, involves egg retrieval, success rate of implantation can vary. Could there be aneuploidies, extra or missing chromosomes that also we know are more common for IVF pregnancies? So this can be a definitely more involved process, but there can be testing in pregnancy as well. For instance, chorionic villus sampling, amniocentesis, are ways that we can test like the placenta or fluid around baby in order to get that mutation analysis done as well. And then families can make any decision that's right for them at that point if pregnancy is affected. But sort of to that question that was asked earlier, what if genetic testing is non-diagnostic? What if we don't find an answer? What then? Certainly testing could be negative, meaning we don't find any change in any gene we currently know of. For some families, that might be relief. Well, at least this isn't one of the sort of known genetic forms that we know of. But maybe it could also cause a lot of disappointment. I really wanted an answer. I wanted a reason why. I'm really sort of frustrated and disappointed that I wanted more information. We didn't get it. Is may or may not have a change to medical management, but that can be a struggle for some families when they know something's still wrong. We have a feature here and we don't know why. The complication here as well is sort of, as I mentioned earlier, we just don't know what every single one of our genes does yet when it's not working on the human body. We have about 20,000 genes we estimate. We know what about 7,000 of them do. So that still leaves about 13,000 of our genes that we can get the sequence. Sometimes in some bigger tests, we can look at that, but we have no idea how to interpret it. So our knowledge is only ever good as the technology and knowledge at the time. And so I expect as we learn more, we will potentially identify new genes and associations. Gene discovery is ongoing all the time, but a negative is kind of only as good as that period in time. But then we may get an uncertain result, where, as I mentioned, we find a single variant that we've just never seen before. This is a complication of how we just haven't identified every single possible type of variant in every single letter of every gene to know fully what everything does. And so oftentimes this might have to be a perspective of parental testing isn't always as helpful unless a parent is affected and we know we can track it through the family. And so we try to sometimes use computational molecules. Is this seen in the general population? What is this variant? Does it fit? As a guess, but oftentimes we have to leave these uncertain. And so that can sometimes cause nervousness, anxiety. What does this mean? Is this the answer? Is this not the answer? What do I do with this? And sometimes we can't always give that answer at that moment. Sometimes we have to let time pass in order to get more information to be able to say more. That could be, again, disappointment of not having a clear answer. It can sometimes be associated with high anxiety. And I think whenever somebody undergoes a process of genetic testing, I think it's always important to consider the fact that I might not get a clear answer out of this. And is that something I can be comfortable with as I undergo this process? Certainly, we always hope when we offer testing, we will find an answer, but we can never guarantee it. And so these are possibilities of what someone might receive when we undergo genetic testing, that we might not get an answer. And I think these can be where an importance of genetic professional can be useful. And so that's why it can often be important to touch base with providers every few years as we learn more, as our sort of panels potentially grow, as we identify more, as our technology increases. It's always possible we may be able to find more over time. Can never guarantee that either, but it's always possible. And so this is kind of where, again, sort of closing things off, that the role of the genetic counselor can sometimes be useful. It's logistics of testing. Where do we send it? How do we send it? Can we get consent? Are we doing appropriate family history? Are we ensuring nothing else is being missed? There could be the psychosocial counseling piece. And so if this is something that is ever of interest, they're both sort of adult and pediatric genetic counselors. You can ask your GP or nephrologist if they know a specific provider. And through the NSGC website, so it's the National Society of Genetic Counselors, they actually have a website where you can find a genetic counselor to your area. That may tell you this is where they're located, and can always reach out and try and get something booked with them at that time. That's the end of my talk. Thank you so much.